I'd like to invite Andy Simpson onto the stage. Andy is someone I've known for a very long time, and he's also a multi-presenter at every Equally Well Symposium. And I think that's testament to the fantastic work that he and his colleagues have been doing at the Living Well, Living Longer program in Sydney Local Health District. And Andy and I actually have a similar vintage of nursing graduates, and both new grads, aren't we? Yeah. But I'll pass over to Andy for him to tell us about what happened during COVID with the Living Well, Living Longer program. Over to you, Andy.
Thank you. Yeah, so sorry to raise that horrible P word again, the pandemic that we're all trying to forget about. Although luckily Livia did it for me as well yesterday afternoon. Are the slides ready? So yeah, I mean, I wanted to start by talking a little bit about the Living Well, Living Longer program. Do I need to click on? Oh, I see. Thank you. So Living Well, Living Longer, just so you know, a very quick overview, is a program in Sydney Local Health District which aims to guide people living with mental illness through these 4 stages of screening, detection, initiation of treatment, and into ongoing management. So that's kind of how we set up. And the way we do that is through a series of care pathways or interventions, particularly focused at our community mental health consumers in the district. We have a metabolic assessment clinic called CC CHIP, who provide comprehensive like a one-stop shop, so an individual can go along and see 8 different metabolic health specialists in one afternoon and get a whole set of recommendations for follow-up with their GP. They operate 3 times a week. We've got a mental health shared care program then, which integrates nicely with our metabolic clinic because people get to their GPs for follow-up. Those recommendations can be enacted, and there's an agreement around sharing of information. This particular program, we also have a couple of CNCs in each of one in each sector to sort of support shared care. We employ health-based peer support workers, so we've got standard sort of peer support workers in the district as well, but the program actually funds what we call health peer workers who really use that lived experience that they have to inspire healthy lifestyle behaviour and choices, and they co-facilitate exercise groups as well in the community. And then we have our diet and exercise interventions or lifestyle interventions, co-facilitating those exercise groups. And we have dietitians and EPs that are integrated as well with that CC CHIP clinic. So it all sort of fits nicely together. So that's a quick overview of the program. Now, the pandemic, I do hope these images aren't too triggering for people, painful memories for some of us, but I just wanted to make the point that very early on in the pandemic, this paper came out in August 2020, there was this recognition that there may be collateral health issues here, that we're going to have to focus so much on this public health response that there are likely to be sort of things left behind in health services. This paper talked about we'll need to make sure the cure is not worse than the disease itself. So interestingly, the World Health Organization in 2021 looked at mortality globally in the year of 2020. And there were 1.8 million reported COVID deaths that year, but there were 3 million excess mortality deaths. And of course, we've all become expert epidemiologists through the pandemic. So, you know, we talk about different countries underreporting COVID, and I'm sure that would explain a lot of that perhaps. But they concluded that the pandemic is likely to have increased deaths from other causes due to a disruption of health service delivery. But we don't really know. So what this particular paper talked about was that medical infrastructures around the world were vastly unprepared and ill-equipped to manage a pandemic, which, if that's a criticism, it's a pretty harsh one, because, of course, health services don't have hundreds of staff just ready for a global catastrophe like COVID-19's come along. So services, the key point I wanted to make was number 2 here, is that, yes, of course, health services did need to rapidly reshift their focus, reorganise services, and really anything that was not considered urgent frontline treatment was just cancelled because the staff were needed to assist in the COVID response. And on top of that, Livia talked much more in detail about this yesterday, but, you know, of course, there was also a global reduction of exercise, mobility, walking, not just for people with mental illness, but gyms were closed, lockdowns and so on, all had an impact likely to have had an impact on overall health. So that was just a quick background in the context of why we started to look at this data in Sydney Local Health District to see what the impact may be. And I broke it down into these 5 areas. So we looked at the COVID-19 vaccinations that we achieved in the district, our rates of metabolic monitoring across the district, our mental health shared care program, which includes those sort of annual physical health checks with GPs, metabolic clinic appointments, and also engagement with our dietitians and EPs. So in terms of vaccinations, we were quite proud of this result. So, Olivia talked yesterday about, people with mental illness actually do want to be vaccinated at very similar levels to the population. But yes, they're likely to need extra support, help to get there, and so on. So a lot of this genuine integrated care that happened in Sydney to make this happen. The overall rates of mental health in the top there was 91.9% receiving 2 vaccinations, not too far off the statewide average of 95%. This was in June 2022, so about 6 months after the end of the Omicron outbreak. And that was a real coordinated approach. We were doing pop-up clinics, we were bringing vaccinations to boarding houses and so on to make that sort of happen. I just wanted to make a point as well that for our mental health shared care consumers, that second row, we actually achieved a rate of boosters higher than the general population of New South Wales. And that's about 650 people in our district in shared care. So that was something else that we were very, very proud of. Obviously lower in our non-mental health care consumers, which tend to be a more slightly disengaged group, I suppose. That's, I'm afraid, though, where the good news ends. When I looked at this data, metabolic monitoring rates, as we went through the red, amber and green alerts of the pandemic, you can just see the decline over the 2-year period. So in the year before the pandemic, we averaged exactly 900 metabolic monitorings completed per quarter. And as the pandemic progressed, this dropped to 564 as a 37% reduction across the district. Contributing factors, well, if you take yourself back to when the first COVID outbreaks were happening, it was actually a pretty scary time. We've sort of blanked it from our memory, but you can kind of understand why clinicians were a little bit reluctant to get into people's 1.5 meters. There were no vaccines at the time in the early stages, and we were hearing these daily reports of deaths in the media and so on. So you can kind of understand why clinicians were a bit reluctant to engage in metabolic screening and blood pressure and waist circumference, all these things where you would have to get in within 2 meters of people. The limiting of face-to-face contacts had an impact. So, these were from quotes from our actual guidelines that we gave to care coordinators. We should minimize, where clinically possible, limit face-to-face contact and minimize consumer attendance at the health centres, move to virtual modes. So, obviously people reading that thinking, well, I don't think it's clinically urgent that I take someone's blood pressure right now. Might be different with a injection, but people were just dropping off doing the metabolic screening. There was high turnover of staff through the district, either through sickness or just general vacancies and so on. And key point is the redeployment. So we would use clinical nurse educators to train all of our care coordinators in metabolic screening, but they weren't there. They were all redeployed to various other roles within the community. So when new staff were coming into the mental health teams, they weren't getting any training or orientation on doing metabolic screening. Mental health shared care program. So a little bit busy slide, but the purple line is the number of people we have in mental health shared care agreements. And the initial outbreak back in April 2020 really had a very minimal impact. And in fact, we really bloomed between the waves. Feels like saying between the wars or something. But in sort of early 2021, Australia was doing pretty well with regards to COVID. There was basically none of it around. And shared care went up to its highest numbers to date, 736 people enrolled in shared care. And we had, the green lines is those annual physical health checks, but the one I want you to notice is that green dotted line, which is people in shared care who have had a physical health check within the last 12 months. And just look how that tumbled, particularly through sort of that big red, and the second red there is the Delta and Omicron outbreaks. Big slide down in the shared care agreements, in physical health checks occurring with GPs. So you can kind of, in order to calculate the impact there, so that previous slide was just sort of quarterly snapshots, which doesn't tell the full story. So in order to calculate the pandemic impact, I just looked at, on average, prior to the pandemic, how many new agreements and how many new physical health checks were occurring every month. And as that we made through the different phases of the pandemic, it just dropped. So you can see by the time Delta hit, we were only getting 5 physical health checks a month across the whole district compared to 32 before the pandemic actually started. Overall, that led to a 20% reduction in shared care and a 60% reduction in physical health checks with GPs during that 2-year period. So quite a shocking kind of outcome there. Again, reduction of face-to-face contact. People were being told, don't drive in cars with consumers unless you can really avoid it. So, were they picking people up, taking them to their GP appointments? GPs themselves were very busy, had other focuses on switching to telehealth, vaccinations, and there were significantly changes in Medicare billing as well. So consumers who would previously get free bulk billed GP appointments invariably were no longer getting that, and that still remains a big issue, unfortunately. In terms of our cardiometabolic assessment clinics, I've just got the annual numbers for you. So prior to the pandemic, we had 477 people reviewed at our CC CHIP clinic, and you can see how that dropped off over the next 2 years. 55% reduction. To be honest, though, actually the true impact's probably much greater than that, because we actually opened a 3rd weekly clinic at the end of 2019. So we were expecting, if the pandemic hadn't hit, for the numbers to be 600 or 700 in 2020, and so quite a big drop-off. Obviously, the clinics were completely closed during red alert phases, an outpatient clinic, and even when they reopened, they were only operating at 50% capacity because of social distancing requirements and so on. So you can understand why there was a big drop-off there. And my final one I want to show you is contacts with our lifestyle clinicians, so with our dietitians and exercise physiologists. You can really see the impact of the red alert phases, and that was basically very, very closely linked to our redeployments that were happening overall. So actually, again, similar to shared care, our data peaked prior to Delta in the middle of that sort of pandemic period. We did really well. We were getting a lot of contacts with our dietitians and EPs, and partly that was because of the might be explained by some of the switch to more telehealth models. We were actually not driving between health centres, and we were actually able to contact with a lot more people through the phone, perhaps, maybe partly explaining that. So yeah, obviously the contributing factors here is the service basically all but closed. We maintained maybe a day a week for our most sort of urgent priority people that we were engaging with through the red alerts, but the clinicians were just redeployed to assist with the COVID response. They were, we had dietitians being the team leaders of vaccination pop-up clinics and all sorts of crazy things like that going on to make the response happen. Reduced referrals as well, and turnover of staff, all these sorts of issues were still coming up. So in summary, the good news is that we did achieve pretty good vaccination rates, 91.9% receiving 2 vaccinations and 61% receiving a booster. But the bad news, 37% reduction in metabolic monitoring, a 20% reduction in shared care agreements, with a 61% reduction in physical health checks with those GPs, 55% reduction in CC CHIP clinic reviews, and 20% reduction in our lifestyle interventions. So overall, now I did say in the abstract, very, very quickly, I did say in the abstract I would give you the latest data. So last week I crunched the numbers. I had no idea what I was going to find. This is what I found. So metabolic monitoring across the district, as we've moved into these yellow alert phases in New South Wales, does seem to be a slight uptick, nowhere near to our pre-pandemic levels. But if you look at the sort of trend line, perhaps things are starting to improve. Shared care has been a struggle, a real struggle, unfortunately, and in fact our numbers of annual physical health checks has reduced even further since our previous slide, but we're just getting a little uptick here at the end in the last month or two, and we're hoping that's the start of a recovery. With CC CHIP, we did increase slightly in 2022, but the services were still operating on very limited capacity. And with our lifestyle clinicians, they are the ones that have made a very good, healthy recovery. We're now running 7 or 8 physical health exercise groups across the district, and we've got a full team. So they've really bloomed in the last, really this year. In conclusion, I think I'm out of time, but what we have found, and most of this data, by the way, is not routinely looked at. With the shared care was an alarm bell, because we do look at our shared care data quite routinely. And that prompted me to say, I think I better look at everything else as well. Otherwise, we wouldn't have discovered that things have really dropped off quite dramatically. So it contributed to a fairly dramatic reduction. Other service providers, like I say, because it's not routinely looked at, other services may not also routinely look at this. And you may not know the true impact that's happened as a result of the pandemic. So I would obviously encourage services to just now redouble their efforts and ensure that we increase our rates of screening, treatment and so on of chronic disease moving forwards from here. So thank you.
Andy, thank you so much for that presentation. It's really good to see the solid numbers that your team has produced in terms of recording what's actually happened, because we all know that there's been hidden costs of the pandemic, but to really clearly see how much things do drop off. And I actually had a question for you because I wanted to jump in first. That's what you can do with the microphone. I guess, programs, a lot of great programs have lost momentum during the pandemic. In your role, what do you see as the way to get these things re-kick-started? Obviously, the sessions with the EPs and dietitians has got back up very quickly. What about the other areas? How do you envisage getting those re-kick-started?
Well, I think it might be a similar problem for other services as well. But to me, one of the biggest factors was the change of staff that happened through the pandemic. A lot of people moved roles, left the service, a lot of new staff coming in. And because all of the normal staff that would do orientation and training were all redeployed, they were just getting nothing. There were also changes in the management in a lot of the teams. So that may not be a unique problem for our district. I think that's probably a fairly shared problem that's happened over the pandemic. So I think we had a lot of new staff coming in at a very busy, very stressful, very difficult time to be coming into a new role in health. The team leader, management was new. There was no tertiary staff. There was no CNCs or educators there that normally help and support people. So I think moving forwards, now we've got these people, now those people have returned to their roles. We've pretty much, I had the CNC, the shared care CNCs would go into the teams and meet with the new staff and say, we need to talk about you've got 10 people on your caseload in shared care, so we really need to get them going in for their physical health checks. And the staff would say, what's shared care? What are you, no idea what you're talking about. So we almost had to start again with training and orientating and getting ourselves back on the agenda. We've been doing in-services with all the teams. We've been training the team leaders, like who we are, what we do, because it was so easy. Suddenly, when you're not frontline, unfortunately, physical health in local health districts is not considered frontline. We're an extra service, and it just dropped off the radar completely. So we're just getting in people's faces again, basically.
Yeah, no, it is a real challenge, as you point out, re-establishing the good culture that you did have around inclusion of physical healthcare. So yeah. I think that's work that needs to be done in practically all places, but it is also an opportunity to establish new things as well with the change. So that's great. Were there any questions from the audience, Randy? Hand straight up there.
I'm Terry Slevin from the Public Health Association. Andrew, thank you for that fascinating content and context. And then my question, Andrew, is about context. And I noticed your title and you talked about the issue of re-engaging after the pandemic. My question is about your awareness of similar kind of programs across the New South Wales system and also the extent to which they might exist elsewhere. My guess is the unit you lead, is a relatively uncommon one across the health system within Australia. But I don't know whether my guess is right or wrong, so I'd welcome your comment on that.
Well, that's a good question. I think districts are all starting to tackle this problem. Really, it's only in the last 10 years that there's been a recommendations, if you think about statewide frameworks and World Health Organization recommendations about tackling this problem. Obviously, South East Sydney have had an excellent program now with the keeping body in mind that's been going for 12 years or so, I think. Andrew might correct me.
I think about 20.
Oh, 20 years, goodness me.
Well, in an earlier incarnation anyway.
Yeah. Southwest Sydney have a program, and I know the program leaders at the back there, so Isabella. So there are things going on across the district, across the state. So sorry, your question particularly? Beyond New South Wales. Well, that I would point you to Russell's talk from earlier in this session, actually. So Equally Well have just conducted an activities scan. So, I'm not an expert. I would say I'm not just to to blow my own trumpet, or the programme's trumpet here, but when I engaged in the activity scan with one of the equally well representatives, they thought that the programme we were offering in Sydney was basically top of the ladder. There wasn't much else happening to the extent that we're doing, unfortunately. But yeah. But other districts are starting in different. They're all at different stages. Yeah.
Right. Thank you. Another question over here, Andy.
Is there any hope of having this sort of process, even just included in other health districts' MHUs? Because my latest experience of an MHU, I could have just been a head in a jar because the rest of me was absolutely moot. I had 2-week-old surgical stitches that needed to be removed, and I had to fight tooth and nail to get them removed. I needed physiotherapy because I'd just had a reconstructed knee, and I could not get it in 5.5 weeks. Even with the psychiatrist putting in a referral for me to have physiotherapy, because it was playing on my mind in such a degree. So I felt like I may as well have not been there. I could have just checked my head in and gone about my way, because there was absolutely no integration whatsoever. Nobody wanted to know that I was a person with a body at all.
Very sorry to hear that. I mean, I hope that health services are attempting to do better. The concept of integrated care has really been growing in the last 5 or 10 years. And this in the last 2 years, yeah. So, yeah. Not getting to the coast, okay. Or Tasmania. Right.
Yeah, look, there's certainly challenges. Sorry, I don't want to cut you off, but I'm also mindful of our people online that can't pick up these important conversations. But yes, very clearly, there's a lot more that needs to be done. I think the great thing about coming into a space like the Equally Well Symposium is that you can see that people are working really hard and trying to transform things. But it's a long and it's a hard battle. But there's lots of good people putting a lot of effort into
these experiences where it just doesn't exist. And it's sort of like a beautiful world where it doesn't happen in other places.
Yeah.
I think that we have to start somewhere, and I think that change in health. I think there was a study that said that evidence change takes about 20+ years to come into health change, we can just start going up the ladder and making things better and integrating better. So hopefully we're on that journey.
Well, sorry. Is it a really, really quick one? Okay, let me get up the back.
Hear this, we have to start somewhere. All the time, we have done for the last 50, 100 years. But in this year's symposium, I have the consumer input is palpable, so I've got a lot more hope.
That's a really good point. Thank you.
Great. Please thank Andy for me on a great presentation.